Welcome to the show discussing problems and issues of health with Dr. Alcena. For this segment of the show, I'm going to continue to talk about COPD emphysema. COPD emphysema is a very common medical problem. Across the world, there are 600 million folks who suffer from COPD emphysema. And in this country, there are 12 million folks with COPD emphysema, and there are another 12 million, we believe, yet to be diagnosed. That will add up for a total of 24 million people who suffer from this very serious condition. And of course, the reasons, as I just mentioned in previous shows, are people who smoke tobacco, be it cigarettes, pipe, or cigar. And of course, the other problems include people who are exposed to pollutant of different types, people who are exposed to asbestos, people who are exposed to coal mine, lung problem, etc., etc., and pollutant from the air, pollutant from the factories, and so on and so forth. And of course, people who have recurrent pneumonias that causes their lung to become scarred, and then they can develop COPD. And there's 2% of people with COPD has a condition called alpha-1 antitrypsin deficiency. That's, of course, a genetically transmitted problem, but it represents a significant number, 2% of the total. Be that as it may, we talk about how people get this condition, and of course, secondhand smoke as well is a major issue as well. And of course, the symptoms are chronic cough, shortness of breath. People have difficulty, basically they're very fatigued, they suffer from headache, depression, they can't sleep well, insomnia, etc. They lose weight. Those who have pink puffer lose a lot of weight. Those who have the so-called blue bloaters that tend to have a little bit heavy chested, etc. So, and the bottom line is there are two different types. The pink puffer are the people who have dry, so-called dry emphysema. They have difficulty bringing sputum up, etc. The people who have blue bloater, they're very heavy set, most of them, and they basically behave similarly to people who have asthma. They can wheeze, they have a lot of secretion, they have to cough up, etc. And of course, the side effects of emphysema, COPD, includes a condition called polycythemia, because of the hypoxic state that they find themselves in chronically, that allow the kidney to overproduce red blood cell, and these people have a very high level of red blood cell, which can then cause them to have stroke, cause them to have a heart attack, and so on and so forth. So that's really, and also dizziness secondary to transient ischemic attack. And of course, at the other end of it, there are folks who develop anemia. And the anemia is because, as I mentioned last week, COPD emphysema, you have an individual who also have ulcers because they over-secrete a substance called histamine, and then that then stimulates acid production, so there's a high incidence of ulcer as well. And you have people who are basically so sick they can't eat, they lose weight, blah, 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 blah. It's a miserable disease. People really suffer immensely from it. Now, in terms of the evaluation, one of the most important tests that has to be done, of course, is the pulmonary function test. The pulmonary function test, in addition to the history and the physical exam, really establishes whether somebody has COPD emphysema or not. And of course, the chest X-ray shows characteristic pictures of somebody emphysema because of the air that gets trapped in there. When you look at the X-ray, it's pretty much all it's black. It's darker than a regular chest X-ray. Folks who are in the X-ray profession, such as the radiologists, we use a better term, of course, to describe that they're superb at what they do. And of course, in the management of COPD emphysema, you need somebody who's in general medicine, who's an internist, who's a primary care doctor, family care doctor, and of course, a pulmonary specialist. These are the folks who basically take care of these problems. Now, I talk about all the evaluation. We've done the chest X-ray, we've done the arterial blood gas, we do the pulmonary function test, etc., etc. Now, we have to begin to treat the individual. There are two different types of presentation. There are people whom we're treating in the office, and the people we're treating in the emergency room. In the office, there are two different types of medication. There's a short-acting medication, there's a long-acting medication. There's a combination of a bronchodilator plus a steroid. Now, the short-acting medication that are frequently in use are some like Ventolin, HFA, albuterol, Zopanex, Atrovan. These are the short-acting medication. They work pretty fast to open the bronchioles on the lung. The long-acting medication that we give folks are Cerovent, Spiriva. Those are in that category. In terms of the combination of medication, then, well, of course, you have Symbicort, that has a combination of the bronchodilator plus a steroid, and you have Advair. Those are the combination type medication. And then, of course, when you come to oral medication, you have prednisone itself, which is steroid. You can give it by mouth, and you could also give Singulair. We give the Singulair usually at night, and an old medication that's still around, Theophylline, Singulair, prednisone are the medication we use by mouth. Okay, now somebody shows up acutely in the emergency room, then of course we're going to treat them after we do all they take the history, the examination, blah, 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 blah. We just do an arterial blood gas, we get a chest x-ray to make sure they don't have pneumonia, to make sure they don't have congestive heart failure, which chest x-ray might help us to determine. Then we're going to treat them with oxygen. Got to be very careful, as I stated last week, how much oxygen we use. If you use too much oxygen, it's going to suppress their breathing, causing them to retain more carbon dioxide, making the situation worse. That is why it's not a very safe thing to give them nasal oxygen, because you don't know how much you're giving. You think you do, but you really can't be absolutely certain. So we use the Ventimass, whereby we could better control the amount of oxygen they're getting. We just want to give them enough to make them feel better, not too much. Too much oxygen, clearly, is not good. It's going to suppress the breathing center at the base of the brain and causing them to retain more carbon dioxide, and they can stop breathing. So you don't want to do that. You got to be very careful, and you have to be sure you know exactly what you are doing. And of course, we give them medication through the nebulizer. We put the short-acting medications into little machine that we give the patient to breathe in, and they hold onto the mouth, they breathe it in, and it goes inside the lung to dilate the bronchiole. I mean, after all, the problem really that we're dealing with is the bronchiole, which is the tubes that go down the lungs, are all damaged, and then those that are producing a lot of secretion, in addition to the chronic damage that has occurred because of the effect of the cigarette. Remember, cigarette have 4,000 chemicals in them. Okay, there's a lot of garbage that's in there, and all that toxic to the lungs, and then of course of that 4,250 of them are carcinogenic, meaning they can cause cancer, etc. So this is a very, very toxic material. We're talking about tobacco now. Again, this is America. People have the right to sell the product. This is a free enterprise system. This is a capitalistic system. I'm a capitalist myself, and people ought to sell things to make a living. However, they have a responsibility to put on the label of what they're selling what damage can occur as a result of the product they're selling. That's where the problem comes in. And as a physician, I could never encourage anybody to touch tobacco in any form, because it is just bad for your health. Case closed. Now, having said that, now we have a patient in the emergency room. Okay, the patient is sick. We give them this little machine here. This is a peak flow meter. When they come in, before we start the treatment, we let them breathe through this peak flow machine to see what's the best expiratory flow they can put out. When they breathe out, boom, they blow it out. So we pick that number down. Then we begin to treat them with the oxygen, with the nebulizing medication, which contain all the short-term, the Ventolin, the albuterol, the Zopanex, whatever combination we want to use, and that is going to liquefy the substance that's blocking the bronchiole. It's also going to relax the wall of the vessel, dilate them to allow air to come in and out easier. And of course, in so doing, air can navigate better through the substance of the lung, which is basically damaged as a result of the toxicity of the tobacco product. Now, it doesn't necessarily have tobacco, it doesn't have to be tobacco, I just stated. 2% of COPD emphysema has antitrypsin deficiency, people who are working in factories where they inhale all kind of garbage. These people they can develop COPD as well. People who are working in the mine because they inhale all that material from the tar of the stuff that they're working with, they develop black lung disease. Very bad as well. And I can go on and give you the long list of things that can cause COPD emphysema. Cigarette smoking and tobacco smoking in general happens to be on top of the list, but it's not the only thing. The list is quite long. Now, having said this to you, now that we've got this patient in the emergency room, the patient may need some IV fluid. Got to be very careful because COPD emphysema can cause congestive heart failure, especially right heart failure. Well, if you have chronic right heart failure, you're likely to have chronic left heart failure as well, because the left heart try to compensate for the work that the right heart cannot do, and so doing, the left heart becomes enlarged and it begins to fail as well. Very, very important to know what you're doing. When I spoke last week, I said to you that when you're examining a patient who has emphysema, in particular people who have pink puffer type emphysema, they somehow manage to the heart, the position of the heart and the chest is shifted. So therefore, the first sound of the heart as we examine somebody usually is felt right beneath the nipple of the left nipple of the period. But now that because of the right-sided disease, it's shifted. It's shifted so that if you're somebody present in the emergency room, you don't know them, you don't know the condition that they have, all you know they can't breathe, and you're examining them. And in the old days, I don't know that they still, in fact, they still do it today. They give people Lasix or another type of diuretics, and they give them oxygen, and they're going to give them morphine. The morphine relaxes the muscle. That's part of a protocol that we used years ago. I don't know that I haven't used morphine to treat congestive heart failure since I left training, and which is some almost 36 years ago now. So, but some folks may still be doing it. Besides, the show that I'm doing goes all over the world. So people in the developing country are still doing this old protocol. Be careful, because if you give somebody who has COPD emphysema morphine intravenously, you're going to likely to make them stop breathing. Okay. So how do you know if they have emphysema? Well, looking at them, first of all, you evaluate them. Listen to the lungs will tell you there's difficulty moving air, and if that was not enough, when the heart shifted, the first sound is going to be right here, right in the manubrium, right there, right there in the center of the chest, because the heart is shifted from the left to here. Right away, you know to back off with your morphine injection, otherwise you're going to have somebody on a respirator in a few minutes. Okay, you don't want to do that. Okay, so now that we're giving the treatment, we're doing all that, we're watching the patient, and then we had already sent her blood tests off, the CBC, the chemistry, and etc. And we sent all that stuff off, and we got the chest X-ray, we do an EKG, we do all that, and then we're watching, see if the patient is improving. If there's any sign at all of an upper airway infection, which can trigger a decompensation of COPD emphysema, any upper airway infection, be it sinusitis, be it a very bad viral infection that causes somebody to have cold, etc. Now, you're going to have to give the patient antibiotic. There is no controversy here. The reason is because the upper airway of individuals who have COPD emphysema is already completely damaged because of the heat of this tobacco they smoke over the years. They have no protection. It's all naked. So, which means that the local bacteria, whose job it is to live there, in your nose and in your mouth, you have bacteria. Down your trach, down your throat, you have bacteria. They live there to keep the area moist, etc. That's where the body is created. That's the habitat. So, when damage occurs because of the swelling that's taking place, the whole area now is at risk to become fully infected by the same local bacteria that was there, that was minding their own business. But now that you've got all this swelling going on, all this inflammation going on, they're going to participate in the infection. So you have a combined infection of viral plus bacteria. We have no acute antibiotic to treat for the virus. However, we could treat the bacterial part of it. I'm not one to be pushing antibiotic on people who have cold. Not at all. However, in this setting, you must. As a matter of fact, it has been proven that when you give people who have COPD emphysema chronic antibiotic they take every day at home, such like tetracycline and stuff like that, they're less likely to decompensate from an acute bacterial infection. They do better, they fare better. That's all over the literature. If you don't want to do that, when they're acutely sick, from here up, or you just treat them with antibiotics. Now, if they have pneumonia, that goes without saying. And the pneumonia, you could hear it when you examine them. The pneumonia, you could see it on the chest x-ray, okay? Then they have to get specific type of antibiotic that we know what to do. We physicians know exactly what type of antibiotic to use that is broad enough that it will cover for all different types of possibilities of bacteria that may be involved. So we use what's so-called broad spectrum antibiotic. With somebody, let's say somebody shows up from a nursing home, they're decompensating from COPD emphysema. Well, they were at a nursing home. They could have been colonized with Pseudomonas. So you're going to have to cover for possibility of Pseudomonas. They could have been exposed to MRSA. So you have to be covering for that, or any kind of other. So you give them vancomycin. You will put vancomycin. You give them medications of ceftazidime, which will cover Pseudomonas. There are a long list of antibiotics that can cover for Pseudomonas. You have got to understand where is the patient coming from. Is the patient coming from home? How long has the patient been home? Was this patient in a hospital a month ago? If he or she was in the hospital a month ago, he or she may have picked up something in the hospital that's still in her upper airway. So you got to take that into the consideration of what antibiotic you use. You can't just say, well, here's antibiotic, use it. No, it doesn't work like that. You have to know, is the patient coming from the community, namely the home, house, their own home, or the patient coming from a nursing home in the community, or the patient was recently discharged from the hospital. That information is crucial in helping you to come up with a broad spectrum antibiotic that will cover for certain gram-organisms such as Pseudomonas, that will cover for possibility of staph and a whole host of other bad bacteria. So you cover for that, okay? You cover the person broadly. That's what physicians do. We use our brain to make judgment. 70+% of what physicians do is based on judgment. Okay? So you treat the patient broadly, they get antibiotic, they get oxygen, then you're going likely to put the patient on steroid. IV steroid. Why the steroid? Well, the steroid is crucial because steroid is a very powerful anti-inflammatory medication. Powerful anti-inflammatory medication. You cannot treat somebody with COPD, emphysema, or asthma, or any one of these pulmonary diseases without the help of steroid. And again, I will mention it again, since this is the last show on COPD. Steroid was developed by a black biochemist, Dr. Percy Julian, that's right, who, because of racism that he faced in this country, he was forced to go to Europe to get his PhD, which he did, and came back. He did a whole lot of incredible things. Among the things that he did, he biosynthesized corticosteroid as we know it. So the world owes this gentleman credit for the incredible invention that he did. I mean, there are many black physicians in this world and in this country who have done a whole lot of incredible things. They don't get the credit because they don't get to be on TV like I do, and other people don't put them on TV because of racism. Let's face it, okay? And me, I have my own show. I've had this show now since 1992. This is not a commercial show. I don't have any people that's paying me to do this show that can get mad at me or whatever, okay? It doesn't work like that. I have turned down several times the offer made to me to become involved in this commercial television stuff. No, I won't do it. Even though you may not know this, and I'll tell it to you, not because I want to be arrogant, but I have a lot of message I want to give to the poor minority folks out there who are struggling to try to get ahead, in particular the youngsters. You know, the youngsters. Don't let anybody shut you down. Don't let anybody tell you you are arrogant because you're intelligent. Had nothing to do with that. They're just trying to keep you down. If you are smart, what's wrong with it? A few years ago, Einstein was having the 50th anniversary, and they had the whole hotel in New York City, Waldorf Astoria, the entire circumference of the hotel covering with sign all the way around saying that, and the sign read, "We are even smarter at 50. Now, the dean, and Dr. Purper, who was a teacher of mine, who did a lot of incredible things to help me when I was in medical school. So I approached him. I said, "Dr. Purper, wasn't that a little too much? Do you have to say it like that?" He says, "Val, let me tell you something. There's nothing wrong if you have something, you show it off. There's nothing wrong with that." He says, "We are intelligent, so what's the big deal?" What's that? It's the big deal. We are better even at 50. So there's nothing wrong with it. The key thing is that it's not to be obnoxious about it. It's not to be stupid and appear to be intelligent. That's a problem. But if you're intelligent, what's wrong with it? That's a gift. Intelligence is a gift of God. Believe it or not, common sense is something you get as part of your interaction through the world. You don't inherit common sense. You do, however, inherit intelligence. It's a God gift that gave it to you. Why would somebody like me, who I was in my yard earlier today with some workers doing some work for me, and I have some gadget in the yard to chase the squirrels away. They can hear the noise. They tell me, the guy said, "This machine, I couldn't hear that noise." The reason that I can't hear that noise is because I work in a factory in New York City in the early 60s that messed up my hearing. I got the gadget, 3 of them in the yard, just not too long ago, earlier today. The guy said, "Well, I can hear it, Doc." I can't hear it because that part of my hearing was taken away because I work in a factory where the telephone, you could hear it when it was ringing, the buzz. It was a buzz blocks away because I was operating this machine for 3 years. It did a lot of damage to me. So how do you think I get to become a professor? Not because my aunt helped me, not because my dad helped me. It's my intelligence. So what's there to be shy about? I'm not ashamed to say I was a factory worker. I'm not ashamed to tell you that I work on the farm for almost 10 years for 20 cents a day, which is 1 Haitian good. So what's the big deal? That's what I had to do to survive. So how would I get to be where I am today, where I can sit here and tell you I was born in Haiti, I went through a whole lot of hell, and yet you can't find a Haiti, a doctor that was born in Haiti, in the history of the country, that has done as much as I have achieved in medicine. And yet, I went to elementary school here when I was 26 years old. What is the big deal? It's the truth. I'm not being arrogant by telling you about it. I'm just encouraging younger people who are being told every day, 7 days a week, female and male, you can't do this, you can't do that. You're not smart enough. You can hogwash. Nonsense. Don't take that stuff. Challenge yourself. Go to school. Educate yourself. Stay away from trouble. There's trouble all over the place. Sidestep the trouble. Stay in school. That's the formula. I was just there. I was just at the Radio Shack a while ago. 2 young people were selling me some battery for my telephone. And this young lady was asking me a question how to get into medical school. I took the time. I took the time in my way to the studio to explain to her what she has to do to get into medical school. I did that about an hour ago. It was my pleasure to do that. These are young people selling. They were selling stuff. The selling is the battery. I just bought battery from them for my little telephone for the office. I took the pleasure in my way here to stand. I stood there and talked to them. 2 young women, telling them how to get ahead. Caucasian young woman. Who cares? I have nothing to do with racial issues. I was helping them to tell them what to do, how to go to school, how to get through the pre-med program, how to take the M.C.P, because they were interested in medicine. That's who I am. So the bottom line is, don't let anybody tell you what you can or cannot do. God gives you a gift, use it to get ahead. Okay? You have to have self-confidence in yourself, what you are able to do. Don't let people tell you what you can or cannot. They didn't bring you into this world. Your mom and dad and God did. Your mom knows what you can do, believe me, because she knows, she brought you into this world. Listen to them. Respect them. Okay? So in any event, COPD emphysema, this is the last show. You put the patient on steroid. Steroid was synthesized by Dr. Percy Julian, black man. He did that. It takes 6 hours to kick in. You give it IV. It decreases the inflammation. Once you decrease the inflammation, that then decreases the secretion, the production of secretion, allowing the tubes in the lung to open up, so air can be transmitted easier, and you decrease the patient's symptom. Until next time. And if the patient goes home, you have to be hospitalized, we continue the treatment inside the hospital. They need antibiotic, we'll give it to them. When we discharge them home, if we have to give them steroid by mouth to taper off for a couple of weeks or so, we do so. And then some more patients go home, they have their own nebulizer. We give them prescription to use their own nebulizer at home so they can put the short-acting medication, give them prescription for it when they don't feel well. They can treat themselves through the nebulizer rather than just using the little puffer. Okay? So this condition then can be prevented if you stay away from cigarettes and other tobacco products, and stay away from all the pollutants and etc. If you can. Sometimes you cannot, because that's the circumstances of life like I had to deal with when I work in factory. Listen, this is it for COPD. Until I see you again, this is Dr. Alcena saying so long and bye-bye.